Thank you, everybody, for joining us this evening. This evening is graciously being hosted by Mount Sinai. We extend our heartfelt gratitude to the entire Mount Sinai team for taking time out of their very busy schedules, for showing us true care for our community members, providing this exceptional team of medical professionals to speak with us on this very important subject. A special thanks to our good friend Nathan Hoffman for his outstanding efforts in organizing this event and his meticulous dedication to the health of our community. Thank you to our partners for this evening, OHEL, Med Council, and the Center. For over 50 years, through partnerships with organizations like Mount Sinai, SBH has been able to provide a vast array of services to our community members. By looking at the family holistically, we're able to support the physical, emotional, and mental health needs of all members of the family. Again, thank you for joining us tonight, and allow me to welcome our good friend, Nathan Hoffman, trustee of Mount Sinai Health System and Chaim Medical Sephardic Division, and a friend to all in our community. Thank you. Nathan?
Thank you, David, and thank you to the SBH and the Mount Sinai team for putting together this amazing event together. Once again, Mount Sinai is at the forefront of not only treating, but now educating our community and our most important demographic, our elders. Our community stands on the shoulders of our seniors and becoming more and more complicated to address their every need. Today, along with the president of Mount Sinai, we have put together a team that will be sure to give you an amazing presentation that hopefully will allow you to leave with the tools that can help you in this very important job as a caregiver. As I said earlier, I started with the words once again, as not long ago, Mount Sinai was treating hundreds, if not thousands, of our community members during COVID. Books have been published about the amazing infrastructure Mount Sinai had during this very tumultuous and fluid time. The advancements that were made on the fly were unprecedented, and I'm proud to say that if not for Dr. David Rich, his guidance, his intelligence, and broad knowledge of medicine, none of that could have happened. It's my honor to call Dr. David Rich my close friend and partner, and it's even a bigger honor tonight to introduce him to all of you to begin the program. Thank you.
Good evening, everyone. As Nathan said, my name is Dr. David Rich. I've gotten to know and really become very close to the Assyrian Sephardic community over the last 4 years. Of course, it began in COVID, but it became so much more. A real bond with a really wonderful community that has so much to offer, and Mount Sinai is proud and honored to be your partner. And also thanks again to Sephardic Bikor Cholim, SBH, for your sponsorship and the ability to address this community that we've grown so close to. I want to start by bragging just a tiny bit. Yesterday, Mount Sinai won the UCLA Hearst Health Prize for AI in Medicine, and I'm hoping we might come back to that in the end a little bit, because as we have become a leader in AI in medicine, I believe there are many applications that we could develop and work on together with the community related to prediction and identification of symptoms or syndromes that we can work effectively together to improve the lives of our seniors. Next, I want to brag about something else, and that is our amazing Department of Geriatrics and Palliative Care. The Brookdale Department of Geriatrics and Palliative Care was founded many decades ago now, and has been not just in our minds a leader within the specialty, but for the last 4 years has been named #1 in the nation by U.S. News and World Report, the top-rated Department of Geriatrics and Palliative Care. I just want to say one thing to the community. I was raised in a religious environment myself, and we at Mount Sinai work very closely with people who are dedicated to following the principles of halakha, and we work with many religious communities around the goals of care that are specific and appropriate for those communities. So I don't want anyone to think as we're going into this that geriatrics and palliative care means anything related to a concept of withdrawal of care. Just the opposite, geriatrics and palliative care is about focusing on the good things in life, trying to improve the quality of life for our seniors. And I believe that the partnership between the providers in the community and the Department of Geriatrics and Palliative Care is a tremendous opportunity for us. So now I'd like to introduce Dr. Sean Morrison. Dr. Morrison is the Ellen and Howard C. Katz Professor and System Chair of the Brookdale Department. He's also Director of the Lillian and Benjamin Hertzberg Palliative Care Institute and Director of the National Palliative Care Research Center. All of this at the Icahn School of Medicine at Mount Sinai, and we couldn't be prouder of Dr. Morrison and the amazing department. And you'll also get to meet two of my other very close colleagues, but I'll allow Dr. Morrison to do that introduction. Thank you for allowing me to say a few words at the beginning.
Thank you, Dr. Rich, and thank you for allowing us to share the evening with you and talk a little bit about what we do, why we do it, and from my perspective, why it's so important. And as Dr. Rich said, I'm joined by two of my friends and colleagues who are going to speak in a minute. Dr. Audrey Chun, who was a graduate of our training program and has risen to become vice chair in the Department for Ambulatory Services. And, Dr. Emily Chai, who is also a graduate of our fellowship training program and is Dr. Chun's counterpart in that she's vice chair for our inpatient services across the Mount Sinai Health System. And together they are an incredible power duo who run all of our clinical programs throughout the health system. I don't think it's an understatement to say that perhaps the greatest advance, or I would say even miracle, of the last century has been the change in human longevity. If we think back, and I was not there, but I am told, if we think back to the dawn of time, 40-odd thousand years ago or so, up until 1900, average life expectancy on planet Earth was somewhere between 35 to 40 years. Life expectancy, wherever you lived on this planet, was exactly the same. And it stayed exactly at that place for, again, 25, 30, 40,000 years. And in the past 125 years, we have seen human life expectancy more than double in the United States. We went from expecting to live around 45 years at the turn of 1900 up to today, where average life expectancy in the United States is 78 years. And if you reach 65, which most of us expect to do, average life expectancy is not 78, but it's 84. And, you know, some of us, if we think about retiring at 65, that means we have almost 20 more years to figure out what we are going to do and what contributions we're going to make. For most of us, the time over age of 65 is one of good health, good physical function. It's time to reconnect with our families, to explore other opportunities. And most of us, at some point in our lifespan, are going to develop one or more serious illnesses, chronic conditions, which we're going to live with for many, many years before we eventually die. And what our program and what our department is designed to do is to ensure that our older adults have the best quality of life and the best possible life expectancy that we can provide through modern medical care. We have some challenges. Longevity comes at a cost. Most of us, as I said, will not have that perfect ending where we have perfect physical function, perfect cognitive function until the day we die. The reality is that most of us will live with some sort of chronic illness. High blood pressure, arthritis, diabetes. 1 in 9 of us, unfortunately, over the age of 65 will develop dementia or Alzheimer's disease. 1 in 3 over the age of 85. And as so many of us know who have aging parents, my father now is 92. As we age, particularly into our 80s and 90s, we're going to need assistance. We're going to need caregiving. By ages 75 to 80, 40 to 60% of us will need some help with our household activities, and 10 to 30% of us will need some help in our self-care. And that places a burden many times on families and loved ones. And as we age, as we move into the future, we're facing a shortage of caregivers. By 2030, the number of people over the age of 65 will be greater than the number of traditional caregivers we have in this country. So what do we do about it? And that's what I think my colleagues and I want to talk to all of you today about. First of all, what is it we can do to ensure that we live as well as we can for as long as we can? Aside from picking our parents. You know, genetics will drive everything. We can't pick our parents. So what can we do to ensure that we do have the best quality of life for as long as possible? What are the resources that are available to help caregivers and to help families who are worried about and caring for an older relative, an older spouse? And as Audrey and Emily are going to talk about, what makes geriatrics different? Why is there a field of geriatrics? What is different about healthcare for somebody in their 70s and 80s versus somebody's in their 30s, 40s, and 50s? And importantly, why is it so important to get access to geriatric care? Because unfortunately, most of us in medical school don't learn about the special needs of older adults. We learn about taking care of quote unquote normal kidneys, normal livers, normal hearts, and those normal organs are in 45 and 50-year-olds. That's what we're taught in physiology. Most physicians in this country, though, will be caring for people in their 60s, 70s, 80s, and 90s. And one of the roles of our department, in addition to providing exquisite clinical care for older adults in the New York City area, is to begin to educate healthcare professionals at every level, from medical students all the way through to practicing physicians, about the core principles of care for older adults. And then finally, as Dr. Rich pointed out earlier, with the AI award and our focus moving forward, is what research do we need to do? And what research do we need to enable to ensure that all of us will have the quality of life that we deserve as we age? I wish I could tell all of you that we will have a cure for aging that will be available to all of us. I wish I could tell you that the cure for cancer, the cure for Alzheimer's disease will be available to our generation and our parents. I just don't see that yet. Hopefully for our children. But for the millions of us who are going to be aging in this country, and the millions of us now who are already in our 70s and 80s, our focus really should be on what can we do to minimize the burdens of aging and to allow us to live the best quality of life. So with that, I think I turn it back with those brief words of introduction. I think I turn it back to you, Dr. Rich. Is that not correct?
Let's see. I will open it up. I think, Dr. Morrison, we're going to ask you to introduce Dr. Emily Chai and Dr. Audrey Chun, if you don't mind.
Not at all. I will do that. So let me start. I see Audrey is straight in front of me, and she's an A. Audrey Chun has been with the department almost as long as I have, but not quite as long. She started as a postgraduate fellow here and rocketed skyward. She initially was responsible for developing and running our Martha Stewart Center for Living on the Upper East Side. And now her portfolio includes all ambulatory or outpatient services for older adults across the Mount Sinai health system. Emily Chai was actually Audrey's classmate as a postgraduate fellow. She initially ran our palliative care clinical programs And when I became chair and we reorganized, Emily's portfolio now includes all of the inpatient services, like Dr. Chun, both palliative care and geriatrics for the Mount Sinai Health System. So if you're in one of our hospitals and being cared for by one of our teams, Emily's your boss. And if you're in any of our outpatient practices, it's Audrey. So Dr. Chai, Dr. Chun.
Emily, would you please start? Thank you.
Sure. So as you have heard from Dr. Morrison, a lot of the focus on what we do in geriatrics, whether it's inpatient or outpatient, is with the ultimate goal of enhancing an older adult's quality of life. And we don't work alone. We work with a team with specialists, physicians, nurses, social workers, pharmacists, and physical therapists. And our geriatric team actually has a good understanding of the challenges that are unique that come with aging. You know, aside from the basics of medicine, what we do in the inpatient setting is we layer on and focus on 4 particular areas in geriatrics. The 4 areas that we call the 4 M's. What matters to the patient, their medications, their mentation, and their mobility. The first thing we do when we meet a patient in the inpatient setting is really getting an understanding of what is the most important to them. Who are they? What are their values? How do they make decisions? Because we feel like we need to know that in order to help them come up with a treatment plan that aligns with their goals, their values, and their beliefs. So you often will see us starting with questions like, you know, what's important to you? You know, what is most valuable to you? And if there are trade-offs, we talk about those trade-offs. I just had a patient who told me that I need to keep her alive until she's 100 at whatever the cost. Also had a patient who told me that she doesn't want to be living a day longer if she cannot be independent. And without asking those questions, I wouldn't know how to come up with a treatment plan that aligns with their goals. We also review their medications. As you can imagine, with chronic illnesses comes many additional medications. They interact with each other. They interact with the things that we eat. They interact with over-the-counter vitamins or supplements that we may want to take. And our expertise in working with a pharmacist is to really be able to recognize the side effects and ensure that, you know, the medications they take are safe and effective. Dosing of medications often have to be adjusted for an older adult because of their kidney or liver function. And that's sort of the second piece that we do. The third piece we focus on is really their cognitive health, or what we call mentation. We assess for dementia, for depression, and delirium because we believe that if we could identify them early, we might be able to intervene and improve their quality of life. Depression by treating it, dementia by making plans for the future, you know, and delirium by really figuring out what the root cause of the confusion is and reversing that. Last, mobility. It's really about being safe for them to go about doing the things that they love. And it's one of the things that we focus on every outpatient visit, every inpatient visit, to make sure, you know, they're not at risk of falls and they continue to do everything that they love to do, right? Once they're hospitalized, the highest risk is deconditioning and muscle atrophy because they're in bed all day. You know, we walk them and figure out what is actually safe for them to do, and we encourage them to get out of bed. So in the inpatient world, we layer these 4 M's, what matters, medication, mentation, and mobility, on top of all the medical care that they actually receive. And that's sort of what we really focus on, with the goal, again, of enhancing their quality of life. And with that, I'll turn it over to Audrey.
Good evening. Thanks for the introductions. And I really want to thank all of you for attending this session to learn more about geriatrics. And whether you're interested in learning a little bit more about how to improve or maintain your own health with age, or whether you're wondering how to plan or what to expect with aging parents or relatives, I really hope this discussion is both enlightening and empowering, and I very much encourage you to submit questions in the Q&A so that we can really address this to the questions and the concerns that you've had. You've heard a brief history from Dr. Morrison about the department and kind of the background of geriatrics and what we can expect generally with aging. But maybe you're wondering, how does geriatrics apply to me personally? What can we do with Mount Sinai, or why should we be looking to them and their expertise? And really at Mount Sinai, we provide both primary care for older adults. So that means all the basic care that's needed, typically for people over the age of 75 and who have some of these conditions that Dr. Morrison and Dr. Chai alluded to. But often as well, because we're not located throughout all of New York, and it's not necessarily convenient to be coming geographically to our practices, we often work as a consult with your primary care provider, your primary care physician, to address any sorts of common geriatric issues and to really come up with a treatment plan to optimize health. As Dr. Morrison alluded to, the really good news is that we're living longer and we're living better. We are getting to advanced ages with better physical function and health and cognition, and it's really wonderful. We also can't deny that there are physiologic changes that occur with aging, and treatments really need to be adjusted to accommodate some of these changes. I'll provide an example maybe to make it a little bit more understandable. I'm sure you recognize either in yourself or in people that you know, a person with several conditions who seems to have a specialist for every organ in their body, right? So they have a cardiologist for their heart condition, a pulmonary physician for their lungs, they have a nephrologist for their kidneys, a rheumatologist for their joints, an excellent primary care doctor, an internist taking care of kind of the whole picture. And really the list can go on and on. And while each of these specialists is an expert in their own area, sometimes one treatment, which is absolutely standard and appropriate for that one condition, can actually make another condition a little bit worse. And as medications get added on, as Dr. Chai mentioned, sometimes, in fact, you might be causing more harm and side effects than the benefits that are actually intended. And this is really where a geriatrician's skills can come in. We can offer a treatment roadmap that is personalized based on what your priorities are, what matters most to you as a patient, what matters most to you as a family, and really try to figure out how to tailor and customize the treatment to minimize the burden of those treatments and really maximize the benefits that can come out of that. And we can assist with coordinating that plan with the many specialists that you may have or with your primary care provider. And to me, this is one of the most rewarding parts of geriatric medicine, that we get to combine the compassion, really listening to our patients and their families and trying to understand what drives them, what matters to them, what's a priority for them, and then using the science of medicine and all the advances that we have to really get to a treatment plan that makes sense for the person in front of us. This is really your time. So I think we've all talked enough, and we want to try to get to your questions and make sure that we address any of those concerns or ways that you wonder how you can help your family or yourself as you approach this aging process.
Thank you, Dr. Morrison, Dr. Chai, Dr. Chun, for that fantastic introduction. I did answer one question in the Q&A already related to access, and I wanted to emphasize for the community that we have established a liaison process for community advocates. I work very closely, for example, with Nathan Hoffman, almost on a daily basis, and we work very hard to make sure that members of the community have access to our specialists. And so we will work very closely to make sure that the community has that access. So we have a question here, and I think I'll just read it out. My elderly parent is in Westchester County. is this comprehensive approach available in the lower county area? And perhaps, Dr. Chun, you could talk about how we work with people who are not, immediately in Manhattan, for example.
Yeah, absolutely. So for Mount Sinai at the moment, that may change in the future depending on what resources we have. But at the moment, we have 3 sites for geriatrics outpatient care. And that is downtown at Union Square, at Mount Sinai Hospital on the Upper East Side, and then at Mount Sinai Morningside on the Upper West Side. And so this isn't necessarily very convenient for a lot of people to attend, and clearly geriatrics needs are important throughout the tri-state area. So when this happens, oftentimes we'll see a person at least for an initial visit, sometimes even through a video visit, although we prefer in person, at least for that first visit. And deciding kind of based on that first meeting where we address those 4 M's that Dr. Chai was mentioning, we come up with a plan. And if there are many specialists involved who seem to be in conflict, then that is where geriatrician can come in. We can outreach, explain, and coordinate what the treatment plan is based on the person and their family's priorities, and can communicate with doctors who are even outside of our system. Sometimes it's a little bit more of a challenge if our records don't connect. And so there might be a little bit of time to try to get all of those records and understand everything that's happening or has happened, especially if someone is 80, 90 years. You can imagine that's a lot of history. So it can take some time, but absolutely, that's one of the ways that we try to coordinate and provide these services beyond even our immediate community.
Dr. Morrison, I believe you also would like to comment on this issue.
Yeah, thanks, Dr. Rich. I think the other thing that I'd like to comment on is the 2 issues that we've both heard raised immediately is how can I get access? And one of the challenges that we face as a field is that there are just not enough geriatricians for people in need. And within our department, that is the challenge that we are working hard to address both within our local community, but also on a national level. And we're doing that in 3 ways. The first is by training more specialists, that is geriatricians, in the knowledge and skills to take care of older adults. At Mount Sinai, we've trained now 20% of the nation's geriatricians. 1 in 5 geriatricians in the country has been trained by Mount Sinai. Our training program numbers 32 fellows, which is 5 to 6 times larger than the average training program in the United States. Again, so that we provide both local and national access. The other thing that I think we're very proud of, which Dr. Chun and Dr. Chai highlighted, is that we're really working hard to change the healthcare system so that it meets the needs of older adults, and so that our hospitals are designed to meet the needs of older adults, not just 60-year-olds like me or 40, 50-year-olds like Drs. Chun and Chai. And what that means is it means working with other specialists to provide the expertise that they need to care for their patients. It means working with primary care physicians, general internists, family physicians, as consultants to help take care of their patients. So it's not necessary in my mind that everybody needs to see a geriatrician. What everybody needs is they need access to somebody with specialized geriatric care. They need access to health systems and hospitals that understand the specific needs for older adults. And that's, why I stay at Mount Sinai, is that health system understands them. And as we all learned through COVID, unfortunately, it means having emergency departments that understand specialized geriatric care. And Mount Sinai developed the geriatric emergency department. It was created at Mount Sinai Hospital. And so even at that acute level of care, the principles of geriatrics are in there as a system level approach. And as we move forward as a health system, one of the initiatives that we have within the department is to train not only excellent clinicians in geriatric care, but to train leaders who will be like Dr. Rich, like Dr. Hernandez, who runs Mount Sinai Queens, like Dr. Bull, Jeremy Bull, who ran Mount Sinai Beth Israel, who are geriatricians who run hospitals. And Dr. Rich always kids me that he's an honorary member of the department. But that they understand how to create systems of care that meet the needs for older adults. And so this is a brand new program that we have. It was launched 2 years ago. We now have 10 fellows. It's one of our most popular training programs.
Very good. Dr. Morrison, just to add to your discussion about access, 2 questions came in. One was about accessing care for someone who is in Brooklyn, another for someone who's in the New Jersey Lakewood area. So I think we should talk a little bit about how the consultative practice of geriatric medicine can work with a primary care physician. In fact, Dr. Chun, you do a lot of that work yourself. Maybe it'd be best if you address that question.
Yeah, absolutely. So we can't be everywhere at once. I would love to be in Brooklyn and in New Jersey and in Westchester, but it's an impossibility. However, we do have primary care providers and internists and really excellent physicians who are scattered throughout the counties and in our geographic area and even nationally. And while they are experts in their field, they may not have had specific geriatrics training, and that's where we can come in as a geriatrics consultation. So in addition to the excellent care that they're already receiving, we can offer a perspective and recommendations related to the type of care that would optimize their health, as well as their function, and kind of match where a person wants to be related to their priorities. And so the way that looks is a person will come to see us in person or maybe via a video visit. Sometimes that works out, although sometimes our patients and families struggle a little bit with the technology. When it works really nicely. And really have that conversation and do an exam to understand exactly what's happening, address the medications, the mobility, the mentation, and can make very specific recommendations or even initiate treatments and therapies to match the plan that's needed to optimize health. And we can communicate very closely with the primary care doctor to make sure that plan takes place. So that communication happens sometimes electronically, sometimes it's the old-fashioned telephone picking that up, and also sending written instructions and recommendations related to that care. So we really try to be flexible, knowing we can't be everywhere at once, and knowing that we can't provide primary care to every single older adult. In fact, this consultative model has worked very nicely for people to have access within their own communities to a doctor that they trust, while also having the expertise in geriatrics to help address some of these issues that have been raised.
Very good. I also would just want to address something which has come up in the chat. I am an Ashkenazic Jew, not a Sephardi Jew, although I speak Hebrew with a Sephardic accent. So I'd like to think I bridge all gaps. And there was a question about whether Ashkenazic Jews have access. And the answer is yes. If you're on this call, it's because SBH and Mr. Hoffman and others in the community care deeply about making sure patients have access. So I would encourage you to continue to use the community resources at hand to make sure that we can do our best to provide access to many of our specialists. Another question has come in that I would like very much to hear Dr. Chai talk about, which is just when should we start considering geriatric care for our elderly patients? What are the signs that it's time to work with a geriatric specialist?
I think Dr. Chun alluded to some of the factors, right? When you have many specialists and you can't put the big picture plan together, that's probably the first sign that maybe you need someone to help coordinate, someone to align all these treatment plans with what is important to the patient. Other times it could be as simple as there are so many medications, and I have a patient who actually even told me, you could give me 4 medications any one day. I was going to be picky about which 4 medications, but it's not taking more than 4. So we have to make some decisions about what is important, what would align with what's important to them. And that's not something a cardiologist, a GI doc, a pulmonologist individually is going to be able to decide. We decide that based on investigating their values and their goals. And we rotate the medications so that the medications that last longer, maybe they don't have to take it every day, and we still get them the best treatment possible, but it may not look like what you would anticipate if you were getting specialist level care. When patients are beginning to forget, right, something is just not quite right about them. That's sometimes a cue that they might need a geriatrician to determine, is this depression? Are they just confused because the medications got mixed up? Or is this the beginning of dementia? It's often very hard to tell and very easy to dismiss memory changes or cognitive changes as, oh, that's just part of aging. But we also see a lot of older adults who are completely functional, who don't have these memory lapses. And it's important to really get to the bottom of the root cause of these memory lapses to better able to provide what they need. Those are probably the three top areas. And then the last part is sort of what we talked about when they're beginning to fall. Probably something we see very, very often, right? Is it the medications leading them to the fall? Is it the fact that they can't see, right? Changes in their eyesight? Is it the cataracts? Sorting all that out is sometimes quite difficult for an internist. And I would suggest if you're noticing that with your older parent, it's probably time to get a consult with a geriatrician.
Thank you very much, Dr. Chai. Another question, which I believe we should direct to Dr. Chun, is related to the programs and protocols that we have in place, especially for addressing the cognitive challenges of our older patients, and specifically with the Dean Center at Mount Sinai that was supported by a very generous grant from the Dean family, of course. We'd like to hear your view of the types of programs you have and frankly, how people can help expand them.
Yeah, thank you for that question. It's such an important one while dementia is not a normal part of aging, it does become more common as people age. And it can be such a challenge for the individual who's experiencing these memory changes, but also for the entire family and the community to see how this really affects everyone. The Dean Healthy Brain Initiative is a really exciting collaboration with neurology, geriatrics, and psychiatry, exactly to get at those protocols and best practices for managing a person through that entire trajectory of dementia and all the different things that may come up, as I think the comment was, as they progress and regress, and there are definitely changes that happen. In addition to this generous gift, we're always seeking additional assistance, and we're very excited that we were chosen as a CMS site for a program called Guide. It's a model that's specifically to address both the family as well as the person who's experiencing dementia, and focusing on many of the non-medical things. Since we don't currently have a cure, we really have to focus on managing behaviors and some of the things that might be changing related to cognitive changes and maybe resistance to certain kinds of care, and trying to figure out how best to address those things, sometimes with medications, but most often without. And it's a real lift for the entire community and for the family. So it takes a village, often we say, and in this situation, it often takes not only a geriatrician, but a neurologist and a psychiatrist to help really manage the different manifestations that can occur with dementia.
Thank you so much. One of the questions that has come up, and I'm trying to sort of generalize it to a theme, is people are asking how they can find geriatric care providers in these different communities. And I expect that part of the answer will probably need to be not just who is a trained geriatrician, since Dr. Morrison addressed the shortage of geriatricians in our nation, but how we will identify networks of primary care providers who interact well with our geriatricians so that we can coordinate services. Dr. Chai, Dr. Chum, will one of you want to address that concept, and maybe we'll take it as an action item to help communicate through SBH and other organizations how we can get people into networks of providers that are connected with Mount Sinai.
Yeah, I can try to tackle that. I think an action item is a good point, Dr. Rich, because we're always looking for people who are good collaborators. We certainly have those that we worked with in the past and are really good partners in taking care of older adults. Our society, our American Geriatric Society, also has kind of a find a geriatrician by zip code. So you could try to see if in your specific area there's a trained geriatrician. But as Dr. Rich mentioned, there are not enough of us to take care of everyone, but that is a good starting place. But I think a good action point for collaborating with SBH and trying to find those networks or to elucidate those networks, I think is a great next step.
Excellent. And something I'd like to ask Dr. Morrison to address is we've seen tremendous development in the field of geriatrics and palliative care over the past decades, and Mount Sinai, as we know, has been a leader in this. And so the question is, how can the community help in supporting us in ways that would enable us to further expand our reach and our ability to care for older adults that really need these specialized services?
Thanks, Dr. Rich. 3 key areas which address both the local and the national need. The first is public awareness and public education, is taking what you've heard today, particularly from Drs. Chai and Chun, so that people know what geriatrics is, they know when they need it, and they know how to access it. The second is that we are committed to ensuring that every older adult in this country has access to the care that they need. And we're doing that in 3 ways. One is through our educational efforts, that is training our specialists. We train, as I said, more than any other institution in the country, but we have some unique programs which we rely upon philanthropy to support. One is our new LEAP Fellowship program, which trains not only expert geriatricians, but gives them a crash course in business and leadership and health system design, so that we can fast track people with expertise in the care of older adults into positions where, like Dr. Rich, where they understand the needs of older adults and they can build hospitals and health systems to meet those needs. If you develop a system-wide approach, if the health system, if the institutions are set up to care for older adults, you won't need as many geriatricians. And we have several programs that we certainly could use support in terms of promoting those further. And then the third piece, which I think is really critical, is assistance in helping to create new models of care delivery. One of the things that we have done extraordinarily well at Mount Sinai, and what Mount Sinai does very, very well, is to leverage philanthropy to create new models of care, demonstrate that they are effective, that they improve care quality, and that they're cost effective, at which point they become integrated within the national healthcare system. As Dr. Rich said, one of the other half of the department that we work with is palliative care. Palliative care was a brand new specialty. It's focused on improving quality of life for people with serious illness. And the entire palliative care program, when it started at Mount Sinai, was supported by the community. And when we could demonstrate that it improved quality and was a cost-effective program, that meant that it could be part of the book of business for Mount Sinai Hospital. And we have done that with almost all of our key programs at the moment. We have a delirium program at Mount Sinai Queens, where we're piloting a work to reduce the incidence of confusion in the hospital. We hope to scale that once we demonstrate productivity. Our early geriatrics clinics were started with philanthropic resources, and we were able to demonstrate the need that, or let me rephrase that, we were able to demonstrate their effectiveness and their contribution to the institution's mission. So in a nutshell, how can you help? One, educate. Educate the public, educate your family, your friends, educate businesses. Because one of the things that we see is if you have an older relative and you're taking time off to take them to the doctor's office or to coordinate their care, you're not at work, and that affects your business. So public relations. Help develop leadership programs which will train the next generation of healthcare leaders in the knowledge and skills that they need to care for older adults, and help us create new models of care and new healthcare systems that are going to be better care for our aging population.
Very good. Thank you, Dr. Morrison. I wanted to ask Dr. Chun to talk a little bit about the development of the Martha Stewart Center for Living and just how a major philanthropic gift was able to take a specialty to the next level. And what is it that makes the Martha Stewart Center for Living so special?
Thanks for that question. Yeah, we definitely would not be where we are today with our reputation and with the care that we're able to provide without the generous gift of Martha Stewart to actually establish the Martha Stewart Center for Living. While we had always had a geriatrics practice since the start of the department, even before the gift, it was in 2007 that a generous gift was started with an additional gift a few years later to help start a practice downtown. What it allowed is, number one, some resources to allow us to provide that whole person team-based care, to provide some of the care that doesn't necessarily bring in revenue in a traditional sort of way. So allowing us to have care coordinators and to allow us to have additional social work to really support the patients, as well as ways to support that social and that aspect that's not exactly about medicine, but about addressing caregiver burden and caregiver support groups, memory groups, and ways to really take care of the whole person as opposed to just the medical piece to it. And it was with that gift that leveraged not only some of the resources to actually give that patient, but it actually gave a higher kind of stakes for the hospital and for people coming. You know, the expectations are higher, and so we've got to rise to that level to make sure that the care provided matches that. We couldn't be under the radar anymore with that gift, and so it's something that continues to give as a result of an initial gift. More resources are kind of put into that and allows us to give better care to our patients, which really is our biggest goal. It also has attracted trainees. So when we're talking about education, that attention allows people to kind of think about, oh, what is this geriatrics? What is this something? Is this something that I'm interested in? So maybe someone who had never even considered it before hears the name or hears about the care that's being provided, and it actually draws them to the specialty. So it's allowing us to recruit in a more effective way, in addition to the direct patient care benefits that we have. So it can't be, and not just with the single donor, but with all of the philanthropy that we've been fortunate to get over the years, has really helped to build our programs and expand our reach so that more patients can be cared for in the way that we think they deserve to be.
Thank you, Dr. Chun. I'm learning a lot, by the way, in this webinar. I don't know about everyone else on the panel, and hopefully our community is also just like me, just gaining a lot of knowledge here about the specialty of geriatrics and just how important it is that we work hard and work together with the community that we're talking to today to support and go further. Dr. Morrison, can you talk a little bit about the LEAP program and tell us what that is and how people can help?
Absolutely. So our LEAP program is a training program for postgraduate fellows, and I'll explain what those are in a minute, which is designed to produce leaders in healthcare. And the way medical education works is that you go to medical school for 4 years. Then you go off and you do your initial training to be either an internist like myself or an anesthesiologist like Dr. Rich. And then after you finish that training, you specialize. So if you're me, you go and learn to be a geriatrician, how to take care of older adults. And if you're Dr. Rich, you spend years learning how to do cardiac surgery anesthesia, much longer than being a geriatrician. And during those fellowship programs, those training programs, we essentially focus on teaching you how to be a really good doctor. And what we've decided to do at Mount Sinai is that you need, in this environment, to be more than just a good doctor if you're going to change healthcare for the better. And what you need is you need to be able to understand how to read a budget. How do you lead? How do you manage? How is healthcare paid for? What are the different insurance programs? How do you manage a hospital? And so what we did is we created a program in which people come in, and over a 2-year time period, they get both their clinical training, which is paid for by the hospital and by Medicare, and they get this business training that is paid for by very grateful donors and philanthropists. And those fellows who are specially selected for that program have a very specific curriculum. They have work with health system leaders on their own projects that they have to complete over the course of the 2 years. And our goal is for them to, within 5 years of leaving us, to be in substantial leadership positions so that they can impact healthcare for older adults in a way that they wouldn't if they were going through the traditional clinician pathway, or B, the traditional route that I went through to become a chair of geriatrics, which was years of sort of on-the-job training, mentorship, none of which was formal, and a lot of which I had to figure out by myself. We don't want people to reinvent the wheel. And so we are doing that both at Mount Sinai, and we have a grant from the Brookdale Foundation to scale this nationally, so that we use telemedicine. We use Zoom platforms to train fellows in institutions throughout the United States with our curriculum. And they do a project in their own site. And so we're really looking to expand that. And that's called our LEAP Fellowship Program.
Excellent. We're going to have to limit it to one further question. And based upon what I'm seeing in the Q&A and the chat, what I'm going to suggest is that we talk a little bit about how we can work specifically with the community that we're addressing today, mainly the Syrian Sephardic community, but a couple of Ashkenazic Jews like me along the way also joining, and that's a wonderful thing. To I'd say as a takeaway, what do you think we should be doing in working with SBH and with Nathan Hoffman as a representative of the community to develop programs that can enhance the geriatric care available to these communities? Dr. Morrison?
I was going to say, who are you asking to tackle that one, Dr. Rich?
I saved the hardest for the chair of the department, Dr. Morrison.
Yeah. So I think there are a number of ways to begin to access and to formally access our services and programs. Yes, we do have long wait lists. I recognize that. It's one of the things that keeps me up at night. And we do have a way, as David said, we have special liaisons for our New York City communities that are bonded with Mount Sinai, that we can assist in getting you in to see our providers. Throughout the Mount Sinai Health System network, we have very good, as Dr. Chun pointed out, very good relationships with our primary care providers who are in the Mount Sinai Health System. And anybody who is in our primary care practices, whether they be in Brooklyn, whether they be in Nassau County, whether they be in the Bronx or Queens, always has access to what we call e-consultation with a geriatrician, so that they can send us a summary of, we're having this very specific problem. Can you help us with it? And we absolutely can. We absolutely can. And that means for people who live, in the outer boroughs, for example, or even Long Island, you don't have to schlep in to see us. And as Dr. Chun pointed out, we are expanding our clinical footprints, that is our practices, as rapidly as we can. As many of you know, space is difficult in New York City. Real estate is tough. And we are working as hard as we can to expand our services. We're doing some other unique things to increase our capacity by using telehealth when we can, by doing some group visits with nurse practitioners, and again, by consulting and co-managing with other providers. For example, our surgeons. So it's a challenge. I hear it's a challenge, and we are very committed to fixing it.
Very good. That was a great answer, Dr. Morrison. What I'd like to say is that we have several takeaways from this webinar. One is that we will look carefully afterwards at all the questions in the Q&A that we did not have opportunity to answer, and we will be in touch after the webinar with answers to those questions. And the second thing is it's a clear call to action, and we will work closely with SBH and other members of the community to make sure that we further enhance our ability to provide that care, whether virtual in the form of electronic consult to a physician in the community, whether it is through other programs that we will develop together. And there's no question that your philanthropy, your support that helps Mount Sinai in this particular area is something that will benefit us all, because we care passionately about our elders. They raised us, they took care of us, they lived through difficult times, and we owe it to them to do everything we can. So I, for one, am very enthusiastic about our ability to work very closely with the community to enhance geriatric care. At the time of COVID, we worked together and we did miraculous things. This is not COVID times anymore, but still another challenge that we can work on together. And again, I keep tooting my own horn, but the team that we built at Mount Sinai Hospital that has developed artificial intelligence applications to identify key problems in the hospital, there is no reason that we could not work together and find the resources in the form of philanthropy to help us further develop AI applications that will support the community where they live, not just when they're in an acute care facility. So that was my summary. Dr. Morrison, would you care to make any closing comments as well?
I think the only thing that I would, and it adds not the right word to that, is that I've been at Mount Sinai since 1990. The Department of Geriatrics at Mount Sinai was the first in the nation, was started in 1982 by my mentor, Bob Butler. And the reason that I have stayed at Mount Sinai for now almost 25 years has been both its commitment to its communities, its commitment to older adults, and its commitment to the health of the nation. And I've been privileged in so many ways to have partnered with Dr. Rich when he was chair of anesthesia, and then worked for him as my boss as chair of president of Mount Sinai Hospital. And it's the commitment of people, of leaders like Dr. Rich. It's the commitment of people like our new leader, Dr. Carr, to the community. That's why I stay. And I'm really excited about the programs we've been able to develop here. I'm very excited about the opportunity to partner with our communities in New York City to make them better. And as importantly, to partner with them to make them a model for the rest of the nation. Because if we can do it in New York City, we can do it anywhere.
Thank you all so much for attending this webinar. We started on time and we will conclude on time. but the conversation is only beginning. We look forward to further communication and dialogue, and look forward to ways that we can work together to create the resources to support the community, and especially as we're talking about tonight, to those who raised us and to those to whom we want to ensure a healthy and a productive and high quality of care in their later years. So thank you all for attending, and I look forward to further discussions with the community on various topics. But this one I found very energizing because it's something we all deal with and something which is just so important to all of us. Thank you so much for attending.